To thank our panelists, Professor Mahibal Sachdev, Professor Namrata, and Dr. Gunchan. Like, we have all realized that we are really having so desperate and the harrowing days with this COVID coming on. But what we have realized that last year, most of our webinars were on CAP, that is COVID associated pneumonia. And this year, it happens to be CAM, COVID associated mucormycosis. And with this massive increase in mucormycosis, we the oculoplastic surgeons now we have to perform the surgery, especially exenteration, like which many of us never want to perform because it is so mentally traumatizing. So I'll be speaking basically on challenges of exenteration, ophthalmology, and beyond. Like since morning, we have been talking about the row, how rhino orbital becomes a rhino orbital cerebral, involving the sinus, involving the orbit, and also the brain. And it has been very nicely mentioned by the previous speakers, like how it enters the orbit, either through the lamina propria or through the retrograde NLD, or it can also involve through endogenous, which is very rare. But once it involves the orbit, it involves the optic nerve, the sphenoid sinus. But the most dangerous situation comes when from the sphenoid it goes to the cavernous sinus, which leads to a vascular thrombosis, ultimately leading to a stroke. So currently, we all know there are no standard of care exists to guide the physician on when exenteration may benefit a mucor patient. And to date, even clear evidence showing that orbital exenteration actually improves your overall survival is still lacking. Still lacking is which variables indicate the extent of the disease and which analytic scheme might predict the progression of orbital mucor with or without exenteration. And today, the literatures fail to provide a broad based information of how physicians determine the need for exenteration in their practice, and thus the decision has to be a close balance between preserving the eye or preventing for the death by the intracranial spread. So this Dr. Santosh has shown so well, and I think this is a must read by all the people who are dealing with MECOR. So nicely they have shown, he has shown the proposed staging of this ROC-CM and also the management. But what I want to mention that the most of the literature mentions what are present indications being the non-salvageable globe or significant proptosis with fundamental orbital involvement, necrosis, thrombosis, vasculitis. So these are what we see, and if we see that it does not respond to conservative treatment, we need to go for the exenteration. But the decision making for exenteration still is become a major challenge because many of the literature does not says that whether exenteration actually it decreases the survival of such patient. So this is a very interesting study which I'd like to share. Here they have done the mathematical calculation on which are the cases we should go for exenteration, where they had taken three main criteria based on the clinical signs and symptoms, based on direct and indirect ophthalmoscopy findings, and based on the imaging, where they had given points 1, 2, 3 basis on the mild, moderate, severe, and also on the basis of the clinical signs and symptoms, they have given score from 0 to 3, on the basis of fundus examination score from 0 to 1, and on the basis of imaging, the score has been given from 1 to 3. And those patients who are having a score of 23 out of 45, so 45 is the total score that is from all this scoring. And those having more than 23, so these are a clear cut indication for exenteration, and which is a very mathematical calculations. So I'll just go to some scenario, like if you see this scenario one, you see this the classic the globe tenting, which we also call the guitar pluck sign. So this is a patient, if you look nicely, you can see this involvement of only the anterior ethmoid and a little bit of the maxilla. But if you look to the posterior ethmoid is not being involved. And if you go further posteriorly, you will see that even the sphenoid has not been involved. So this patient basically came with a loss of vision, and this is basically due to CRAO, which I'll be describing how it was being managed. So there are situations where the patient might come only with very subtle changes, which already has been mentioned by previous speakers. Like this is a patient who had the involvement of the posterior ethmoid, involvement of basically the anterior and the posterior ethmoid, but you see the maxilla appears to be clear, but here the patient had Onodi cells, so there he has come with a loss of vision. So when do we need to do exact exenteration is still a big dilemma. But even in situations, sometimes we cannot keep on waiting, like this case, which I have taken from my fellow when she was in her PGI days. So this patient came to us with a very aggressive form. And initially, the patient did not have sphenoid involvement. But within 3 days, if you look to it, the patient had a sphenoid involvement. And before the exenteration could be done, the patient had succumbed to that. So what we have realized that decision making from exentation is still a challenge, and which Dr. Santosh had already shown this very nice article of highest number of cases of 923 cases where they have studied the outcome of the disease, and they have shown that those patients who are treated with surgery and antifungal, they have a survival of 70 percentage. Another interesting study which was reported in BMJ 2018, where they have studied the globe survival, and they have, this is a retrospective study of 79 eyes of 63 patients with biopsy proven ROCM, and where they have found that concluded that exenteration did not affect the patient's survival. It is the frozen eye and the nasal mucous involvement which was significantly associated with low survival, and the higher WBC count significantly increased the risk of exenteration. So in this study of 79 eyes, 45 had undergone exenteration, and out of 45, 9 have only survived with a survival of only 20%. So similar study a year back where they have taken 20 patients of MICOR, where 9 were ROCAM and 11 were ROCAM, and they found that even patients who did not undergo surgery, 50% were treated with amphotericin B alone and they could survive. But this Mittinas, present publication is something which we need to look, because this is one of the latest publication, including all the mucor patient in the COVID having COVID. And here she had taken 6 cases where all 6 patients survived, and out of them 33, 2 of them had undergone orbital exenteration, and they have been surviving for the last 6 months. So we do have challenges, like the previous speakers have already mentioned. Anesthesia itself is a big challenge for such patients, especially we operating with the PPE kit, and we keep on debriding, and we keep on debriding till we get the bleeding periphery. We need to use judicious amount of amphotericin B, and the next important is the daily dressing of the socket. So this is the same patient which I had shown to you, which came with a CRAO. So when this patient was ultimately managed by an exenteration, so when that exenteration was being done, you could see that there was a CSF leak. The CSF leak has been managed very well with this fat that has been taken, and the CSF has occurred because a monopolar cautery has been used during the removal of the apical tissue, which has led to the tear of the dura, and this has led to the CSF, and which was very nicely managed by the modified butt plug technique. So we do have lots of complication. Even if we do an exenteration, these patients have got lots of complication that you can see here. So another challenge is, how do you reconstruct? Normally, as because it's an avascular bed, we let it to go by spontaneous granulation. But there is again debate to it, because many of the surgeons feel that we should do a flap, we should give them a flap, because this will give some amount of blood supply to this avascular bed, and this will help in the entry of the amphotericin B, even the post-operatively. But the most important is the long term, the problem in relation to the psychological and the cosmetic rehabilitation. So this is a very interesting study on the psychosocial changes in patient following exenteration, where they have shown that even when the exenteration is done, they are satisfied with the surgical and the medical treatment, but they're very uncomfortable with the cosmesis, with a 60% suffering from unwelcome comments. And this is so sad that 50% gets uncomfortable stare, and 60% of the patient, even if they're with the closest relation, they're very uncomfortable with the company of the relations, the family and the relations. So another important study, this is on exenteration, but on cancer patient, they have mentioned that we really need to do a very strong psychological and a counseling and a cosmetic rehabilitation in this patient, because people sitting next to any patient with this orbital and facial disfigurement avoid to sit next to them. So if we look to this, we know that though small, it has a magnified topographic representation in the cortical homunculus. And so even if the disease is ultimately abated and controlled by all the intravenous amphotericin B and by exenteration, but it not only hampers the visual information processes by the brain, but causes a realism of disfigurement, which really wants a great psychological and the cosmetic support in such patients patient undergoing exenteration. So I feel that even today, the exenteration is the most radical surgical attack because it leads to persistent physical, psychological, and the social effect. So we should set up a best practice guidelines, and also our OPAI along with AIOS is taking an initiative to form the guidelines of which other patients should actually go for the exenteration. And the previous speaker has also mentioned, Dr. Atul has mentioned so nicely that only those patients in the initial 1 week, they are very serious condition and they should be managed very, very aggressively. So what I want to mention that we should give a very good cosmetic consultation to this patient and give the best of the prosthesis, because this is a really challenging situation who really suffers. And before I end, I would like to end with a positive quote of Noel Helm, that who mentioned that being disabled does not mean unable, it is just differently able. Thank you very much for your patient hearing.